It's my honor, an unexpected honor, to introduce Dr. Bob Harrington. Bob is one of the great thought leaders in cardiovascular medicine, and I would say in medicine at large. I met Bob when he was the director of the Duke Clinical Research Institute, and then when he became chairman of medicine at Stanford, and I was glad that he did because it enabled me to return to Stanford. And Bob's leadership is exemplified by his election to be the president of the American Heart Association. David looked at Bob when he said the Stanford gang. I wish he were still there, but he's dean of Weill Cornell and provost of medical affairs for Cornell University. And I'm going to get off the podium so you can hear from Bob Harrington, a true visionary in medicine.
Well, thanks, David, and thanks to the organizers for having me. When I first got invited to give the talk on cardiovascular prevention by my friend Mike McConnell, I said, Mike, you do know that I'm an interventional cardiologist. And but over the course of the years, as I've been more and more involved in cardiovascular medicine, my attention actually has turned more and more to the early detection, the establishment of risk, and how do we get more aggressive about treating patients at risk for cardiovascular disease, in addition to those who have documented cardiovascular disease. I hope my talk does two things for you. One of which is I hope it depresses you a little bit. And the reason I hope it depresses you a little bit is for my second point, which I hope it will spur you to action. When I first read the papers that I'm going to reference that came out as part of the 100th anniversary celebration of the Heart Association, I was deeply depressed because, as Mort has shown, the stats at one level look pretty good, and at another level, they look pretty horrifying. And so I hope that in a group like this, we can actually bring together different constituencies who are interested in the early detection of disease, I would say in the early detection of risk for disease, and really help us all do something about it. Here are my research and consulting relationships. Probably most relevant for this is I sit on the board of directors for the American Heart Association. Well, as I noted briefly, the American Heart Association in 2024 is celebrating its 100th anniversary, and I'll talk about why that's relevant. But maybe for the non-cardiologist and the non-cardiac researcher in the audience, I point out all the time that since the late 1940s, the American Heart Association has supported almost $6 billion worth of cardiovascular and stroke-related research. And so after the NIH, the American Heart Association is the largest supporter of cardiovascular and cerebrovascular research in the country. And so what I'm going to try to walk you through is about 100 years of progress, but give you the latest heart and stroke statistics. And so you can start to think about the challenges that we as a community have ahead of us. We'll talk about research, and we'll talk about some of the things that I think are coming. Over the course of the last year, the journal Circulation, which is the main journal for the American Heart Association, it has a series of related journals under the banner of Circulation, but the main journal of Circulation has published a series of papers. And in that series of papers, we've really reflected on, as a group, our progress of science. And it really is science that's driven a lot of the changes in cardiovascular health in the country. But also, what does the future look like? And what we as an organization, and by extension, what we as a group of stakeholders interested in the health of the country need to be doing. It was founded by these six gentlemen in 1924. They signed the Articles of Incorporation at the Drake Hotel in Chicago. We recently celebrated the 100th anniversary and the signing of the Articles of Incorporation at the Drake Hotel. I suspect it looked a little better in 1924 than it does in 2024. But I also include this picture. This picture is of Lewis Connor. And I put this in here because it has both a New York City and a Weill Cornell medicine connection. Lewis Connor was one of the 6 founders of the American Heart Association. He was also the first president of the American Heart Association. And at the annual scientific sessions, the presidential session where the president has an opportunity to give an address to the audience, it's the Lewis Conner session. Lewis Conner was also the 2nd chair of medicine at what was then known as Cornell Medical College. And I learned this from one of our senior faculty members who's written extensively about Lewis Conner, his contributions to American medicine. And then with his help, we found in the archives at Weill Cornell, Lewis Conner's portrait, which had hung for many years, but it had been relegated to the archives at this point. And so this is hanging outside my office now for the anniversary year. And I use it as an opportunity when people visit to reflect upon a couple of things, one of which is that the work continues after 100 years. And secondly, that it does have a strong New York City connection. And if you look, several of the founders of the AHA resided and worked in New York City at the time of the founding of the organization. And this is the graph that a variant of this that Mort showed, and he correctly pointed out the issue of age adjustment. We have seen marked improvements from 1950 to 2021, but look what we're starting to see at the tail end of that. At the tail end of that, we're seeing not just a plateauing, but we're seeing a reversal. And we're seeing a reversal in the progress that we've made across the landscape, whether we look at heart failure or coronary artery disease, things are getting worse. And they're getting worse for a lot of reasons that I'll talk about. But I want you to keep in mind that the progress that's been made has largely been made from 2 perspectives, one of which was public health implementation. And the Surgeon General report in the early 1960s around the dangers of smoking was a big part of that. And a large focus of the American Heart Association has been on tobacco control since the 1960s, and we've made enormous progress. As many of you know, with the vaping epidemic and the switch from vaping to combustible cigarettes, there's also been a reversal in some of that, particularly amongst the young people. And so it's something that we have to be vigilant in. The second big public health implementation is around blood pressure control. And the Heart Association has been vigilant in terms of working to control population-level blood pressure. But since about 2020 and the pandemic, blood pressure control in this country has gotten considerably worse. And so while major public health advances have occurred over the last 50 to 70 years, we're at danger of losing ground. One of the most important papers that comes out for the cardiology and stroke community every year is something called Heart Disease and Stroke Statistics. It comes out annually in the winter, and it really is a fantastic compilation of more data than you can imagine, about split by various subgroups, split by different diseases, different diagnoses. And it really is trying to provide researchers with one source of baseline data that's updated annually, with highlighting of certain elements of that heart and stroke statistics that we can all take away. And one of the things I like about it, and maybe it's the visual in me as an interventional cardiologist, is great infographics. And if you look at the infographics here, what you can see is that there's some pretty humbling statistics. Somebody in this country is dying of cardiovascular disease about every 30 seconds. That's extraordinary. And we should be able to do better at that. And you can see every 3 minutes and 14 seconds with regard to stroke. So we have work to do. We've made great progress, but I don't want us to stop. We have a lot of work left to do. And a topic that we're going to focus on, and I suspect that David Maron and Mike McConnell and others will focus on, and that is the notion of behavior. Our sleep patterns affect our cardiovascular health. Whether or not we exercise, what kind of diet we eat. All of these lend into an increased risk of cardiovascular disease, and these are things that we can talk about in prevention. Now, here comes the really depressing part. I was actually one of the reviewers for these 2 papers that I'm going to talk about today, and when I provided my review, in the top line, I said, these papers depressed me, because what it is, it's a forecasting. It's a modeling exercise. So take that for those of you who say, well, that's not real data. It's modeling the data. It is modeling the data. But this is what you have to do from a policy perspective, to look forward to see where might we be going if certain trends persist. Where might we be going and what might we observe if we don't make changes in some of the behaviors that we're seeing? So forecasting the burden of cardiovascular disease and stroke through 2050. And when I first saw the title, I said, 2050? That's a long time away. Actually, it's not. 25 years from now. And if we're going to make policy change, and that's what a lot of this is going to take, policy change, it's going to take that long to exert an effect. So take a look at the paper. Karen Joint Maddox, she works at Washington University in St. Louis. She's one of the great policy investigators in the cardiovascular community. And it's built around this concept. I said that behavior matters. Heart Association talks about this concept of life's essential aids. In fact, if you look at the risk of having a heart attack, it's not in your genes that's predicting that. It's in how you respond to a variety of behavioral aspects of your life: diet, exercise, sleep, whether or not you use tobacco, controlling your blood pressure, controlling your blood sugar, how much exercise do you get, what's your weight. This explains about 90% of the risk of having a heart attack at the population level. And that's been well worked out by the McMaster Group through a series of large international epidemiologic studies. But the burden of cardiovascular disease is largely built here. I also put this up here as we begin to think about prevention. Coronary artery disease is actually preventable. Is it completely preventable? Probably not. But if we had perfect adherence to life's essential aid, we would have a lot less global burden of coronary artery disease and, by extension, other cardiovascular diseases. So life's essential aid. Here's the model data that I find both interesting and really disturbing. This is the prevalence of disease, of all cardiovascular disease, and then some individual things which really drive that accumulated total cardiovascular disease: atrial fibrillation, coronary heart disease, heart failure, and stroke. Everything's going up. And if you look, we're talking about a prevalence in the adult population of about 11% today, going up to about 15%. Think about that at the population level, given the size of our country of about 330 million people, about 220, 30 million adults, going from 11% of something to 15% of something. That's an enormous increase. This is not sustainable from a country perspective if this happens. And if you look at the individual numbers of people affected, look at the numbers here. Right now, we have a prevalence of about 27, 28 million patients of any cardiovascular disease. Look what it would be by 2050, almost 45 million. Again, that's not sustainable from a care in the country perspective. And it's affecting all of us. If you look at some of the various subgroups here, some groups it's affecting disproportionately given the size in the population, but look at the increase here. It's across all groups within the United States. And so I think the conclusions here should be sobering to all of us, that the prevalence of many cardiovascular risk factors and cardiovascular and cerebral vascular diseases will increase markedly over the next 30 years, absent intervention to change these trajectories. And that's critical phrase, absent interventions to change these trajectories, and put that into the context of what you're going to talk about for the next couple of days. And we need both clinicians, but also the public health enterprise to urgently try to figure out how are we going to manage, even reverse these adverse trends in cardiovascular disease and stroke. And this should be a priority on the national level. If you go around the globe, cardiovascular disease is the globe's leading cause of death and disability everywhere except for sub-Saharan Africa, and it's increasing in sub-Saharan Africa. So think about that. Everywhere in the globe, this is an issue. Rob Califf, who's currently the commissioner of the US FDA, published this viewpoint paper in circulation around the time that the pandemic was going on, and really brought light to this notion of, with the pandemic and beginning to understand other common diseases, that we don't even see this coming necessarily. and the increase in the burden of cardiovascular disease, he's called the tsunami of chronic disease. Again, this will overwhelm us as a country if we don't think about how to manage this better. Commissioner Califf will actually be at Weill Cornell on October 15th to spend the day talking about the burden of cardiovascular disease and other chronic diseases in the country. It's going to be a New York City-wide event with health system leaders and public health leaders from around the city coming to spend the day on campus with Commissioner Califf. And if any of you are free, we will have some public events throughout the day. Okay, I gave you the medical data. Now, if you want to be really depressed, let's look at the economic data. And this is the same group of individuals, Karen Joint-Maddox and Dhruv Kazi, were really the leaders of these efforts. And this is, again, forecasting, modeling the economic burden. And if we look at hypertension, diabetes, hypercholesterolemia, you can see the requisite increases that are going on at the population level. And look what this is doing. Look at the cost here. Whether you're talking about total cost, healthcare cost, productivity losses because of mortality, productivity losses because of morbidity, this is not sustainable. If you think about we're already spending about 20% of gross national product for healthcare costs, look at this. This is just not sustainable from an economic perspective, and we have to be able to bend this curve. Not surprisingly, it predominantly affects the Medicare population, given the aging of the population and the age for which Medicare largely serves. But we also see increases across other types of insurance, private insurance, the Medicaid insured population. So this is going to affect the entire population, all of society, unless we do something about it. There's things that are going to be more from a policy perspective than they are from an individual perspective. From the Heart Association, we've written a lot about the disparities in care that are in rural America. We see this in New York State, in some of the rural areas of New York. We saw this in California, some of the rural areas of California. We also see this from a global perspective as we think about as well with migration across the globe and the disproportionate burden of cardiovascular disease across that migration population. We also see from other policy perspectives some of the things like air quality that are affecting the burden and the risk of particularly atherosclerotic disease and heart failure. And so these are other things that you need to begin to think about. How do we affect at a policy level things like air quality that are contributing to this burden of cardiovascular disease? So it's a behavioral issue at the individual level, but there's also issues at the public health issue level that we have to take note of and begin to think about how can we impact that. From a Heart Association perspective, we really think that science and research is what's going to drive progress. And one of the great series of papers that you can access, all available this year as the 100th anniversary celebration, are all of the what's been called the Centennial Collection of where has science been in these key areas and where is science going? And how do we really begin to understand things like clonal hematopoiesis as a science topic, but how there might be areas for therapeutic intervention as we begin to understand the association between clonal hematopoiesis and coronary artery disease. And there's going to be a lot of new types of science that are going to drive where we go from discovery. And this is fantastic for what I would call the secondary prevention of cardiovascular disease. But we really also need to move things towards the primary prevention. And I included here one of the papers on policy strategies. And I'd encourage you all to take a look at this because you say, well, what can I do? Here's the most important thing you can do. You can vote because who we vote for matters in terms of the policy arena around health. So I'm going to make 4 points about how do we bend this otherwise depressing curve. Because I went from sort of through the Kubler-Ross stages when I read these papers. I went from depression to acceptance, and now I'm dealing with how are we going to get active and how are we going to really address this? Number one, for those who have established cardiovascular disease, as a community, we continue to need to focus on discovery, on clinical research, but an area that's woefully underused is, and Mort talked about this, implementation. We need implementation of new approaches to acute care. How do we continue to lower case fatality rates in these diseases like heart attacks and stroke? For those with established cardiovascular disease, in addition to the research arena, we need to focus aggressively, and this is something that Mike McConnell's book addresses, aggressive secondary prevention, both at the individual and population level. And I would include improving air quality as an important part of the population aggressive secondary prevention. Third, and this is really getting into what you're going to be talking about the next 2 days, we need to improve risk assessment and screening using both clinical and technology tools, including imaging and artificial intelligence, that can really allow us to focus on prevention, primary prevention, primordial prevention. At the Heart Association, we're very interested in maternal health, in part because it predicts long-time health for both mother and baby with regard to cardiovascular risk. And finally, policy. We really need to, as a community, and this is a great thing to talk about, that last slide that David showed on all the groups that are coming together to really push for policy changes around physical activity, sidewalks in neighborhoods that need it, safe places to exercise, tobacco control. You want to make the biggest difference in public health, get rid of tobacco. At the Heart Association, we call this the tobacco endgame, and we're completely committed to this. Air quality, insurance coverage expansion, and other issues related to policy. I didn't know that David was going to push the books of Mike and Bruce, but I'll do the same. These are two fantastic books that really address what I've been talking to you about today. More aggressive treatment in Mike's book, Fight Heart Disease Like Cancer. And in Bruce's book, we got to detect these diseases earlier. So early detection. Bruce talks about cancer, but it really pertains to cardiovascular risk as well. Thank you for having me. I'm happy to answer questions or just move to the next section.
Bob, as you know, now you are not only a cardiovascular leader, you've been for 20 years, you're also an executive in charge of policymaking. How can we make a difference in terms of reaching people who are asymptomatic? You know, these people, they don't feel anything, as you know. There is no pain for coronary calcium or in lung nodule. And so what we're trying to get some brainstorming done here is in implementation, because if we implement what we know, no new discovery, if we just implement what we know, we can break the back of our disease, lung cancer. What are your thoughts on implementation?
Yeah. So on your second point, we've written extensively about this over the years. If we just implemented what we know, what would be the incremental add, and particularly my area of interest has been coronary disease. It's enormous. In fact, it outweighs new discoveries if we can just implement what we know. So your point's really well taken. On the other part, I think that there's an opportunity to do what David and Claudia did years ago, which is to launch new programs which deal with screening as a tool to detect previously undetected or unknown disease. I'll mention two things that we have underway in Weill Cornell, one of which is a clinic dedicated to cancer risk detection, in particular GI cancers and breast and ovarian cancer, run by two early career faculty members who are trying to understand, based on family screening, based on genetics, based on a variety of other risk characteristics, how do we just identify people at risk? And then how do we apply therapies like imaging therapy, technologies, et cetera, to be able to really drive that point home of early detection? So kudos to the pioneers of doing that. Second, we have a research project getting ready to start on whole body MRI imaging as a way also to detect disease, not as the tool you sometimes see it online advertised. Hey, you want to find out if you have anything funny going on? Get your whole body MRI. We're going to do that as a research project. So I think we can do more and more things like that.
Thank you.
Hey, Mike.
Yeah, thanks so much for coming and setting the stage for this. I really wanted to dive a little bit more, and Mort already started around this, that, you know, I think the AHA, you know, has been amazing around life essential aid and laying out both for cardiologists and the general public around the importance of prevention. You know, as you indicated, I think we're not doing well enough on then treating it as aggressively as cancer. And trying to learn from that community. But you know, a lot of what we're talking about here is that screening phase. So I talk about sort of trying to implement the prevention when detected, more aggressive treatment. But I think there's still this disconnect in the cardiovascular community, which is very different from the cancer community, that yes, you can try to do your best with prevention, but between age and risk factors catch up with us, and many of us are not perfect on the prevention side, and we have these tools for early detection. So I think really a lot of what this conference is about is learning from the experience of Claudia and David and all the work they've done, and really leaning into screening, right? Even if you just look at MESA, if you go onto the MESA website, put in your age, et cetera, most 1 in 4 men in their 40s and 1 in 4 women in their 50s will have a positive coronary calcium scan. And most people are just not aware of that. So I think trying to uplift the screening element is probably another key message that I tried to convey. And this is a great opportunity to work with the lung cancer screening community to uplift that on the cardiovascular side. So, I think, how do we get that more in the conversation?
Yeah, I'd say 2 things. One of which is we who are involved with the educational aspects of training next generations also have to do a better job at the aggressiveness with which prevention is needed to be implemented. One of the great advances in cardiovascular medicine, for example, has been things like bypass surgery and coronary stenting for certain conditions. And yet the words, I was interested in David's slide about the word choice. We use terrible word choice. Have you ever heard a surgeon go talk to a patient after they've had coronary bypass? Well, I fixed you. You didn't fix anything. You went around the problem, hence the name of the operation, bypass. And so and how many times have we all seen patients go home? Oh, you can stop that. You can stop. It's like, no, we need to get more aggressive because we know you have the worst form, the most advanced form of the disease. So I think we have to do a better job with that, Mike. And that has to be really from day one. The second, I do think at the policy level, we have to be pushing for changes. We have to be pushing for expanded coverage of certain imaging technologies that we know are going to save lives. And so as an advocacy group, the Heart Association has all of this on its advocacy platform.
Yeah, I think I use the concept that if we're treating just end-stage disease, you're taking out the tumor that you see, but you're getting it when it's already quite advanced, and 2, you're sort of underplaying the broader chemotherapy for what's really a systemic disease that's just going to keep coming back unless you treat it more like cancer does.
Agreed. And for those who want to hear more Mike and I talking, you can go to my podcast on Medscape and see Mike and I talking about this topic. Just a shameless plug for my podcast.
My question has to do with randomized controlled trials. You mentioned the Surgeon General in the early 60s who made a proclamation without the benefit of a randomized controlled trial to show that cigarette smoking causes cancer.
Yeah.
We have so much evidence with coronary calcium, and we have the U.S. Preventive Services Task Force saying, can't recommend it, there's no clinical trial. How do we move forward without? I'm hoping that we'll do a randomized controlled trial, but how do we move forward without that evidence?
Well, as you know, David, I'm a clinical trialist. So I do think that for some things, the randomized clinical trial is the gold standard. If you want to compare A with B, there's no better way than to randomize A versus B. But there are other questions where observational, non-randomized data is quite appropriately used. And, Sir Richard Dahl, who was one of the real leaders in the Oxford group that really put forward the notion of the relationship between smoking and human diseases. He talked a lot in his papers in the 60s and 70s about when do you have sufficient evidence from non-randomized data to really drive home a point of certainty. And it's things like, biologic plausibility and what are the exact associations. And he goes through a whole series of steps, and the relationship between smoking, tobacco use, and cancer is pretty clear when you go through all of that. And I think we have to remember that there are times that the observational data is sufficient to make the point. I know that you know that JAMA has recently made a decision that it will allow causal language in certain cases of publication of observational related research. And a group of biostatisticians and epidemiologists who are writing a lot about when is it appropriate to use causal language. I was at a conference last year at the Harvard School of Public Health on causal language and what does it take in cardiovascular medicine to be able to use causal language. Bobby Ye's group at the BI has done a lot of this work at trying to understand how you do that. So I think the community is coming along, and we have to do a better job of using good observational data with appropriate analytical techniques to be able to make those pronouncements.
Thanks.
Last question.
Is the public is inured to this partially because they talk to this person about this in medicine, they talk to that person about this, and the message is so fragmented that the totality of what you're talking about gets diluted by the structure in which we approach this problem. How do we get over, and Bruce Pyanson's going to get into this, how do we overcome the balkanization of healthcare?
Now that I'm a dean, I'm not supposed to give sarcastic answers, I've been told. But one of the things I would say to you, number one is you're right. Number two is that our insurance and payment system really drives all of this. And there will, I've said this from the stage before, so I can say it again. There will be no change in the practice of American medicine until we figure out a better way to pay doctors. And because right now it's the payment system to get paid piecemeal that drives the balkanization that you're talking about. And one of the things that I think really has to happen is wholesale policy change that allows doctors to get paid differently so that maybe, and I won't say definitely, but maybe we'll behave differently. And but I agree with you, and I'd love to chat more, that we're thinking about what is it that we can do to try to help with that. And because it's a mess. It is a mess.
Well, I said that was the last
Oh.
question, but Bruce seems so eager to.
Yes, we have.
Thank you very much. And I really appreciated, the inflection that you demonstrated. As we know, socioeconomic drivers overwhelm medical drivers, including medical prevention. And so I think your call to vote is very important. But I'd point out that when we look around the world, and this is international, doctors get paid lots of different ways across the world. And there's lots of different ways of doing it. Outcomes in the US are worse despite much, much, much higher spending. So I think if we look at some of the socioeconomic drivers and focus on those, I think we'll find ways forward. I'm afraid that medicalizing, we're not going to solve this with medical solutions, not that we should push ahead as fast as possible.
You're 100% right. And when I talk about this in what I'll call in a more expanded way, I talk a lot about the social determinants of health. I talk about structural racism and its effect on health. The Heart Association has written a lot on both of these. And if you look at the Essential 8, there's nothing fancy there, right? It's pretty straightforward things. But if you look as well as the disproportional impact of all of those on different populations, we see worse outcomes, even when you account for the fact that, the blood pressure is only modestly different, for example. So yeah, that to me falls into the policy realm. And we have to figure out ways as a society to be better about this. Your point is really well taken. Thank you.
And the final question.
So I started a model that you're discussing in 2010, tobacco-related diseases and lung cancer screening program. Taking that opportunity of lung cancer screening to identify emphysema and heart disease, patients are very motivated by that. In fact, they're, I would say, arguably more motivated when they see coronary artery disease. I'm with you. We need policy change, but often when we're thinking about policy change, we think about coverage and reimbursement. And I would say that a program like that didn't have a chance to survive because from the top down, we also didn't, we suffer from structural racism within our health systems. And we have we need buy-in from leaders within our health systems as well to have the courage and the boldness to flip this paradigm and endure the tough times that we will face when we are flipping from a fee-for-service to a value-based arrangement with payers. I mean, it's going to take everyone, including the purchasers of healthcare, the folks that are on the front lines of delivery, and those who are responsible for that. And our health systems and our leaders don't have an appetite for that. So we all have to really kind of move forward with a total shift in what our priorities are and what we're willing, what the cost is going to be from every aspect in order to save lives, particularly for those who are the most marginalized and at the highest risk. I know I'm speaking to the choir here, but it's going to take everyone.
Yeah, I agree with you. You know, the group at Intermountain, you probably know, in Salt Lake City has talked a lot about waste in healthcare and has written a lot about it. And as you know, they've moved a lot of their system towards a value-based system. And in part, they can do it because of the captive nature of the population that they have there. And they really believe that health systems won't make the change until you have somewhere in the range of 25 to 30% of your patient population in value-based contracting. That's when it starts to make sense for a system to really wholesale go all in on value-based care. They also have estimated that somewhere between 30 and 50% of what we do is wasted. And part of, I think, and this gets to the gentleman's question who asked about the balkanization and the payment system, part of what we as the profession need to do is get that out of what we do every day.
Well, it's also economies of scale, right? And thinking about our efficiencies of workflows and care delivery models. And it's really, it's really looking at things from a population standpoint, really thinking about group counseling, modeling, where you can bring volumes of people in to address issues. But again, it's a workflow, and it's also optimizing everyone, all of your workforce, not just loading this on the front end of a doctor's plate.
Could not agree more. When I leave here, I'm actually on my way to do my EPIC training because I just got my privileges at Weill Cornell. I'm going to start seeing patients at the end of the month, and I have an hour and a half dedicated to EPIC training. So I get it.
Thank you so much,
Thank you.
Bob.